Welcome back, everybody. Today I have Zarina Vitebsky with me. She is a pelvic floor physical therapist. She is the owner of Pelvic Health NJ. I don't know if you say New Jersey in that.
Jersey, yeah.
It's like NJ. We're going to discuss a couple topics that are related to the pelvic floor. So welcome to ICU, Zarina. Would you mind introducing yourself to the audience?
Yes, thank you so much for having me. My name is Dr. Zarina Vitebsky. I am old school PT. I graduated with master's 1,000 years ago, now 24, and got my doctorate from Purdue. It was labor of love. And then I decided that I love studying, so I'm a perpetual student. So I got my another doctorate in therapeutic pain specialist. Then I got my dry needling degree. Then I got a degree in hypopressive. And now my obsession is gut.
We
So
love that.
because a lot of patients come to me and they say, if you treat pelvis, now you got to treat up the gut. So I'm also certified in Burrell, so visceral mobilization. I do a lot of manual because I'm certified through Stanley Paris, all manual. And so I figured gut would be just so good in my toolbox.
Yeah, why not add another thing?
Absolutely. Yeah. So thank you so much for having me.
Yeah, no, I'm excited to talk to you. It's funny. You and I were just talking about how you worked with my doctor, Dr. Eckenberg. So, and he's been on the podcast before in one of the earlier episodes, but it's just such a small world. And I'm just really glad that we got connected over LinkedIn.
Absolutely. Yeah. And I figured I see nutrition, you must be brilliant. So let's connect. And because in reality, I don't understand nutrition. So I will pass it on to somebody who's actually brilliant in it. So yeah.
Thanks for calling me brilliant, even though we just met. Oh my gosh. Okay, so two main topics that we want to dive into today are TMJ and menopause.
Mhm.
So, why don't we start with TMJ? So, that stands for temporomandibular joint disorders, I guess you would call it. So, can you give the audience a brief explanation of what that entails?
So I am going to say what the patients feel and present as, and then I'm going to give you the clinical side of it. So
Okay.
the patients come into me and they say, I have very stiff neck, and every time I chew, I click, or I cannot open my mouth, or I wake up and my mouth is very sore. And or some people will go to an ENT because they constantly have earache, or some people go to an ophthalmologist or an optometrist because they say behind my eye I have this horrible pain, or they go back to ENT and they said it's my sinuses are just clogged. They don't realize that the jaw, that that hinge gets stuck, it has a little disc inside, and you have all this muscular attached to it, and the jaw, it's supposed to open and close and slide, and that mechanism fails, right? And we usually tend to chew on one side of our mouth. I chew on the right side, so I'm probably going to fall right into my side of my face at some point. We never switch. We have to be very mindful to chew on both sides because we're grinding the teeth on one side and becoming a little lopsided. But so the patients come to me and they say, number one thing, either we cannot open our mouth or we have horrible pain, and everybody's massaging their cheeks like this, right? So they go to the doctor and the doctor says, well, these are your choices. I could put a steroidal shot into it. Great. It makes them feel amazing for 3 months and the symptoms all come back. Physicians can inject Botox again, 3-6 months, they feel amazing, but that's just taking away the symptoms, right? The problem is not solved. So after they go through all of that, they come back and they go, all right, nothing is helping. I can't stand the pain. So now the clinical side of me says to them, your structure failed. And they go, we have no idea what that means. Take away the pain, please. So I have to study this patient. So I take off their shirt. and they're shocked because they're standing topless in front of me, but they came with their mouth to me. And I have to explain to them that once the structure fails, everything by 3 degrees starts to go out of whack, right? So I say to people, I also take into account what age these people are. I usually see girls who are entering puberty, so developing a chest, and they're getting hunched over, they're sitting over the laptops. They'll come with a joint issue, and mothers will say to me, she doesn't want to eat. I'm like, yes, she does. Yeah, she just failed structurally. So, and I will ask, at what age did you develop breasts? Right? What sport do you play? Are you a gamer? Like, I actually ask, what are your habits? And then I study them. And I usually see their thoracic spine becomes kyphotic, their head translates forward, so their cervical spine translates forward into extension, their humerus rotates inward, and now the jaw is protruding forward and the disc slides out. They're thinking that they're just grinding, so they're shoving that brace or their mouthpiece in their mouth, and they wake up with this thing out of their mouth. I'm like, you need to translate your neck back. And what usually happens, in order to bring the neck back, we actually have to go all the way down into the diaphragm because they caved in, and that gave them kyphosis from this kind of sitting or developing a chest. That's younger people. Menopausal women come to me with this. It's because estrogen left them. Goodbye, right? And now they're losing collagen and they're losing muscle bulk. So they're actually going back into flexion. We're born in flexion, we always go back into flexion. And now their cervical spine goes forward. We also drive this way and we sit this way. We breastfeed this way. So it's the same story. So what do? We usually release all of these pterygoid muscles and masseter and temporalis. They feel amazing. 2 hours later, it all comes back. I said, don't try to fix your jaw. Try to fix your structure, because that's the tail of your dragon. The head of your dragon is actually your spine and your neck.
Okay.
Yeah.
Yes, it does. It does. And by the way, for anyone listening to this, if you would rather watch this, I'm going to be posting it to YouTube because Zarina is very animated and she's pointing at stuff. So if you feel like you would learn better visually, definitely go do that. So yeah, I definitely am really interested in this topic just because I suffer from this. I have lots of jaw pain. I grind my teeth. My cavity fillings are falling out, and it's just like a major headache, both physically and for my wallet because the dentist isn't cheap.
So structure. Right?
Yeah.
I also have patients who come to me with tinnitus. They're ringing constantly and there is no cure for tinnitus. And I said, why don't we dry needle your masseters and I will work on your pterygoids, and we would stop stimulating your auditory nerve and their ringing comes down. And I give it to them as their homework. I'm like, don't come and see me. Do this once, go do your thing, and then come back. And I give them postural exercises.
Mm-hmm.
Also, I always throw this as patients are walking out of the room because, I have to give them a shock factor. I say, embryologically, and they go, what? Is she going to embryology now? I said, embryologically, we're all plates. So if you ever wonder, the dura mater in your head, the palate, the vocal cords, your diaphragm, your pelvic floor, and your plantar fascia in your feet are the same plates. So when you develop into a neural tube, as a little blastoma inside your mom's uterus, you're still microscopic. All these plates separate, and that's what makes a human being. So we all vibrate in the same frequency. So if you get a headache and you're grinding your teeth and your vocal cords are a little bit different and your diaphragm is tight and you can't pee and poo, and all of a sudden you came from running and your plantar fascia is on fire, same tissue, same frequency. So it would be a really good diagnosis for patients to say, I kind of have all of those symptoms. So which tells you it's not just TMJ. All of your plates are failing you. Yeah.
Mm-hmm. So for the people who have all of these symptoms that you're talking about, like what's the first step here?
So the first step, if patient comes in and I do all of this quick rundown and they say, I have all of these plates vibrating, I always go into their neck and I activate their vagus nerve, because their vagus nerve is their parasympathetic, right? It calms them down. So the frequency of those plates vibrating slows down. And I teach them how to stimulate their vagus nerve on their own, right? Lots of flicking, lots of ear pulling, because that's where vagus comes down, right? And I put a little vagal stimulator on them and I leave them alone in a room and I said, deep breathing 50 times. And I put a box of gloves on their belly, big belly, and I leave them to calm them down. And then I do the evaluation and I say, how do you feel now? So that's a first step. But when we get up in the morning, the alarm goes off, we wake up and we're like completely cortisol driven, right? We're like, and the day goes, you will be vibrating at very high frequency. So I think the way we start our day and the way we end our day should be calmer. I know it's really difficult to say to patients, like, don't pick up your phone. Like, slow down, take 10 breaths before you get out of bed. I know, but this is the way to make little changes. So for these patients, I do say lots of tapping, because this is what how you talk to your nervous system, right? Lots of pulling. And you know where we learned this from? Kids who have special needs, right? They tap themselves, right? So we realize that's how they calm the nervous system down innately. So we should learn from them. So we do the same. We have these expensive machines that vibrate and you put it on your chest and you pay $1,000 for it. Like, why? You could do this yourself or drive in a car and hum. That's frequency for your nerves. And the nerves hear that frequency and they calm themselves down to that same frequency. So you could calm your brain down.
Mm-hmm. That's really interesting. Is every pelvic floor physical therapist trained to do all of what you're saying, or is this something that came with your various certifications outside of pelvic floor?
I feel, I can't speak for others, but I don't know if everybody studies neurology or embryology. I am just a perpetual student, so I always read one article a day. I don't know if everybody does it.
I don't think they do.
I know. But I'm also, my head is like a bucket of waste information. I love garbage information. I would like to know that flies taste their food with their feet, and that, right, and that praying mantis is endangered and they eat their mates. I love information like this. So when it comes to body information, I study it all, because I realized pelvic floor is your basement and you have this huge structure on top of it. And if I don't know what the structure is, my basement will always be unstable. So when patients come to me and they say, so I have this thing, what are you going to fix? And I go, from your eyelashes to your toes. That's what I'm fixing. It's a whole body that needs to be fixed in order to fix anything else. You come to me for the shoulder, I'm going to scan you and study your entire being, because something failed. This is just the side effect. Where is it actually coming from? That's what I want to know.
Mm-hmm.
And I explained it to the patient. I said, do you want to fix it or do you want to put a Band-Aid on it? Right.
Yeah. Yeah. There's a lot of Band-Aid solutions out there. And
it's okay. Some patients like, I love a Band-Aid. Just give me a Band-Aid. I don't have time for it. I get it. Yeah. So I gear my treatment towards that. But a lot of my patients, most of my patients, 95%, they're like, we're here for the long haul, right? And I always say, we will become best friends for 1 year. And they go, no. I go, you'll see. Yeah.
Did they really say no?
They're like, no. I'm like, but yes. Yeah. And I literally show up to every treatment with a diagram. I go, today we're going to study this. Tomorrow we're going to study this. So when they leave and I go, what did you learn today? And they go, I learned that my palate is the same thing as my pelvic floor, as my diaphragm. And if I release one, it releases the others. I go, congratulations. You're closer to becoming pelvic floor therapist. Yeah.
That's so funny. But I mean, it sounds like you do a very comprehensive evaluation and you work on a lot of things. And, you know, in my experience, I've seen 4 different pelvic floor physical therapists before, and I don't think one even asked me about my jaw or any of these symptoms. So I guess my concern would be like, if that's my experience, you know, I'm sure not every physical therapist is like that, but, you know, if somebody is listening to you and they have all these symptoms, but they're either not in PT or their PT isn't going over that stuff with them, like what can they do?
They could listen to podcasts. I know.
Yeah.
I know. And the problem is, Kelly, that for 24 years, when I say to people, I'm a pelvic floor therapist, they all say to me, what is that? Or my favorite physicians will say to me, I heard of that. What do you mean? It's like me saying, I heard of primary physicians. What does it mean, heard? We are part of the medical team, but for some reason, we're like the unicorns of medical field. But once the doctors get a hold of us and they know what we can do, they love us. It's because we baby their patient and we carry them and we address it all, right? Because we're very educated. We do neuro, we do ortho, we do urology, we do gynecology. And I think when a patient comes to you with pelvic floor issues, we realize this is the end of the bus. Where did it come from? So we always try to trace it back, and it's never really pelvic floor. It came from somewhere else. So we have to be super educated. But for patients, I don't know how patients would know what they're supposed to ask. Because like, you know, you and I, we know because we live this field. But I feel like for patients, sometimes when they come from another pelvic and they say, oh, this has never been done, I don't know what to say. Because everyone practices it differently.
Yeah, I think sharing this podcast with your practitioners, I mean, hopefully they don't take that the wrong way, but you could be like, listen, I heard this podcast and this is what this practitioner is doing and it's really helping her patients. Like, is this something that we could discuss? Are you open to listening to it? Like maybe that could go over well. I don't know.
Not.
Oh, darn.
Some are incredible. They love it. They're like, tell me all about pelvic floor, but others, they don't have time.
Yeah.
Because we're all super busy and we timed to that clock, right? We always watch the clock when we treat a patient. Yeah. So I get it. It's a little bit different now.
I wonder if the people who aren't even in PT yet and are looking for a physical therapist, like if there are certain questions they could ask when they're out, you know, shopping for a practitioner, maybe they could ask these questions.
I know. They could go on hermanwallace.com and there is a zip code. They could punch in their zip code and it drops down all of the practitioners who are certified in pelvic floor. I've gone through all this extensive education and took the extensive exam. So at least they would know that their practitioner is really educated and there's at least the schooling part of it.
Yeah. I mean, but the downside to that is just because somebody did the schooling doesn't make them like an above and beyond type of practitioner. Like I can already tell that you are, you know? So,
you know, when I call it's like dating. So if you and I meet on Match, right? I want to know what your standards are versus mine. You need to date your practitioner for a second there. You can make a phone call and say, I would like to speak to you for 5 minutes. I have this diagnosis. What can you do for me? And if they say to you, we're going to use a biofeedback unit, and then you're just going to exercise, and we're just going to give you homework, and you have to ask, how much manual are you doing? Time-wise, are you doing orthopedic? Are you doing internal? How much is external? How much is structural? You could ask those questions, and then you could judge what the therapist is telling you, because they kind of should be doing both. Yeah.
Okay, I like that idea a lot.
Yeah.
All right, awesome. Is there anything else you wanted to say about this topic of TMJ before we move into menopause?
Sure. I feel for TMJ, don't concentrate on your jaw, please. Try to move your jaw, massage the muscles, right? And stick it right behind the jaw. I drive like this. People wonder, sometimes I'll gua sha my muscles of masseter in the car because I have no time, but it comes from your neck, your sternocleidomastoid, your scalenes, your upper trap. Fix all of that. Have someone work on your neck, professionals, of course. And this is what husbands are for. They need to massage all of the neck muscles. They're free. And then have someone just adjust your neck a little bit to make sure that your rotation is intact, your side bending is intact, right? You could look up diagonally, and if that's intact, watch what happens, right? Look at all this platysma. You could stretch it yourself. That's all for free. And then see what happens to your jaw.
Wait, what is platysma?
It's this ugly muscle.
Oh, okay. She's touching her neck, everyone that's listening.
I'm so sorry. Yes, I look like a lizard, right? I'm flailing this. It's attached to the bottom of your jaw, but it's also attached to your clavicles, right? So this whole thing brings your jaw forward, and now it changes the structure of your neck.
Okay, got it. Yeah, that is definitely.
It's a lot.
It is a lot. And I'm currently learning in like live. You're all hearing me learn a lot of this for the first time. So this is really eye-opening.
We always say to patients, TMJ is not TMJ. TMJ is a failure of your neck, your clavicles, your pecs, your shoulder, your scapula, and the connective tissue and the muscles attached to it. It has nothing to do with this. Yeah.
Right. Now, is some of this stuff that you're talking about with that can be done with a physical therapist? And I don't know if this is a stupid question or not, but can a chiropractor help someone with this?
They do.
Okay.
Really good chiropractors can address TMJ. Some dentists are now trying to address TMJ. And orthopedic PTs are incredible to address TMJ. You don't have to go to pelvic, but if you feel that you might have TMJ and there is something going on with your pelvic floor, like difficulty peeing, bladder, constipation, pooping, pain with sex, now you know the connection, right?
Yeah. And so many of my clients I know have issues with TMJ. And so I think this episode is going to be really helpful for people. And now they know what questions to be asking when they're shopping for a physical therapist. So love that. Okay, so let's transition into good old menopause.
Let's do it. Yes.
So,
ladies and gentlemen, I am opening the door myself to menopause, and I'm hating it.
oh my gosh.
Yes. Yes.
All right, let's start with what is menopause.
Menopause is only, of course, applicable to women, and that's when all of your hormones are just crashing down and your ovaries no longer have eggs in it, and your mouth and your eyes and your private parts are getting dry because you're low on estrogen. Your progesterone is tanking, so now you have depression and anxiety and insomnia. Your testosterone is failing, so you're losing muscle bulk and collagen. It's called slow death, but we can catch ourselves. There is a way, right?
Okay, tell us the way.
Yeah. So, but the question was, so when I was getting certified in menopause, the question on the test was, there's premenopause or perimenopause, menopause, and then there's postmenopause. Perimenopause lasts for a year. That's when your period gets funky, You have it, you don't have it. It's 7 days, it's 17 days, it doesn't show up. That's your peri. That's 1 year. And then you go into your menopause, and that's the body saying, oh boy, I'm going to slow down. And then post-menopause, that's when you're like Sahara Desert, and it's not fun. However, we always say to people, there's natural way to fix all this. So I am very homeopathic. I do believe in hormonal replacement therapy with the right physician. So it depends where you are at this game. So I am entering menopause. So I watch my hormones. So I right now took a Dutch cycling map hormone test, and it tells me where my hormones are now. And then once I go past a couple of years, I'm going to do it again just to see how quickly they're decreasing. There's a blood test that every physician can give you that will tell you where are you in menopause, what stage. So just for fun, if you want to know. But you will know it's because your body's changing so drastically. You're like, I have a tire around my waist. I can't lose weight. My digestion is terrible. My hair's falling out. You know. So I always say to people, like, if you want to go the natural way, you could boost up estrogen. You could boost up progesterone by taking things like wild yam or black cohort. That's all homeopathic stuff. And it does boost you up. But I always say to people, you really want to fix your gut, because that's where your hormones are really being produced at this point, because your ovaries are shot, right? So we produce hormones in our fat, in our bones, in our muscles, and in our gut. And so I always say, I don't know how to control hormones in my bones. And it's really hard to control your adipose tissue that usually produces estrogen. We're just getting a lot more of it. But the gut, as you know, it's under our control. So I always say to women, like, if you have a choice of having cravings and you're just like diving head first into dessert, I'm like, back up a little bit. You know, afterwards, you're just going to pay the price because you're going to plummet your body function. So usually I educate my menopause women as I'm fixing their pelvic floor. I talk about every other system, and I say, exercise. You need that balancing for your bones. The trabecula in your bones, the structure, the spider web, it's not made out of calcium, it's made out of minerals. Take your minerals, buy the little packages, put it in your water. If you don't like that, use Celtic salt. It has 85 essential minerals. Put it in your water and stimulate your bones. Go for a fast walk, right? Jump on a trampoline a little bit. Anything that causes a little stress to your bones, we're going to take care of that. And the joints, right? For the muscles, they have to exercise. They don't have a choice. So research shows they took a young woman who doesn't exercise, and they took a menopausal woman who does exercise, and they checked their body function. The menopausal woman that was exercising was much healthier compared to the young woman who didn't exercise. So that tells you the only way to build a muscle bulk is a little bit of weightlifting. We have to. And I take bone broth protein because I need collagen to come back to my face, because these wrinkles gotta go, right? So, and I take protein, and women, we're so known not to eat protein. I don't know what's wrong with us. Go to a good professional, let them calculate how much protein do you need eat per day, put it in your plastic container and just eat it. Because without that, you're just wasting away. But what do menopausal women want to do? We realize we're gaining fat, so they're depriving themselves of food and they live on lettuce. I'm like, stop doing that. You're literally killing yourself. Eat your protein, and lettuce is just going to give you gas. So, and I was like, have your protein and then have your salad. But women don't understand that concept. They're like, no, that's just going to make me fat. I'm like, it is not.
No, it's not.
Right. And I'm like, wake up, have a quarter of a chicken breast. And they go, that's disgusting. I'm like, no, you need that. Jumpstart your metabolism. Have almonds in your pocket. Put it in your mouth. You always want to stimulate your metabolism. And then do something lovely for your gut. Like have chia seeds pudding, right? Have a little MCT oil and have a little mint tea just to calm your gut down. Take pre and probiotic to build that microbiome.
Mm-hmm.
We could do a lot for menopause.
Yeah. Can you talk about what happens to the pelvic floor during menopause?
Yes. So when estrogen decreases, we start to lose collagen and muscle bulk, right? So when that happens, your structure starts to change. So instead of having, after we had the babies, right, we were super lordotic. Now we're going into kyphosis, and our gut, our transverse abdominis muscle becomes protruded. And now we're changing the intra-abdominal pressure. Once you change the pressure, the guts are coming down with gravity. So now your uterus, your colon, and your small intestines, they're all obeying the gravity and they're coming down. And that changes the function of your gut, right? So women come to me and they go, I have more gas and I'm a little constipated and I kind of pee and I never empty and I think I have a UTI. And I go, it's because your transverse abdominis failed you and you were developing the fupa and now the guts are living in it. We got to pick them back up. I actually have some women who will wear this tiny, soft abdominal binder to keep their guts up so they don't prolapse them down. And then I make them take vital collagens or bone broth collagen. I'm like, drink it and eat it, and protein. And we put them on strengthening exercises at home, but in a bridging position or a downward position so that they don't prolapse their organs. And then, of course, they come to me and they go, my hips are tight, my sacrum is tight, my back is tight, I have pain with sitting, I have pain with sex, I want to sit on the toilet, I can't poo, I can't pee, they're miserable. So we do put them on 0.01% estradiol cream, and they put it on the urethra, a pea size of it, and then they put it around the labia. So now we're going to fluff up that area and the moisture is going to come back. So now they could have intimacy, right? We also do estradiol for them. It's because if you don't have estrogen in your vagina, E. coli takes a field trip right into your urethra. And now these women go, I constantly have a UTI, but it's E. coli. How can I have E. coli in my bladder? I'm like, there is no defense, right? So we take care of that. Then we take care of the constipation because their colon is so loose from lack of collagen and the motility slows down, peristalsis is slow, and they're constantly eating their salads, they're overbulking themselves. They're like, but I drink so much water. I'm like, but then you have like a potato sitting inside. So we got to move that. So I am not a nutritionist or dietitian. So I give them really basic instructions. I'm like, drink enough, don't overdrink because you're washing out your sodium and calcium and which coming out of your bones. And at the same time, don't overbulk yourself. Give yourself slippery things like chia seed pudding, slippery elm with water, jug it in the morning, right? Aloe. But I always make them put a little pinch of cayenne pepper because that stimulates all of your muscles. And I go, if you're not willing to do a lot of work, at least put it through your mouth. Nutrition is the way to go.
Mm-hmm. I can imagine people listening to this like cringing at cayenne pepper, but
a pinch. It's a
pinch. It's really not gonna affect the majority of people what I see.
Not at all. It's a pinch. I was blown away when emergency room doctor said to me, if somebody's having a heart attack, like flat out, right? They're about to die. Take a teaspoon of cayenne pepper, mix it with water, shove it in their throat, and it actually reverses heart attacks. So that tells me how amazing cayenne pepper for muscle, right? So, and I was like, but a pinch, that's okay, right? And I know I see people cannot have their citrus or anything that is they're on oxalate diet, but the pinch of pepper is not going to make a difference, right?
Mhm.
And
Right.
I never introduce acidity in the gut because I think we're acidic enough. And if you want to test yourself, take your pee, put litmus paper into it, and it's going to tell you how acidic you are in your body. If you really want to know what's in your poop, have a GI map performed. They're going to give you a spreadsheet of everything that is wrong when it comes to your colon, if you really want to know. Yeah.
Okay. So there's a lot that can be done, is what I'm hearing.
Yes.
So I'm trying to think of where I want to take this next. What types of things do you do with your PT clients who are going through menopause?
So number one, I always say to patients, let's fix you externally. Don't lie down on my bed and I'm going to release you internally and I'm going to fix you, because the minute you're upright, your building is sitting on this basement. So I fixed this basement for nothing. I just tortured you. So I always do full analysis of the external structure and I write down line by line what is wrong with them. And then I say, goal 1, fixed cervical spine. Goal 2, thoracic. And I explain why. And of course, I'm shaking a spine in front of them and I'm showing it to them because it has to make sense in their head, because that's what motivates them. So I always fix the spine and I always level the pelvis. That's pelvic floor 101. And I make sure that the legs are the same length. And then I do a really quick ART. I lay them on their back and I vibrate their feet. And then I come to their head and I push their head down. And it tells me the waves, the way the body it responds, where they're stuck in connective tissue up front. Then I flip them over. Now their back is up. I do their feet. I do their ischial tuberosities, their sit bones. And then I do their head and their shoulders. And again, I look at the waves where they end up. And I say to the patient, tell me where is it? Because I know you can feel it. And they pinpoint exactly where I can see it. And then I tell them where their connective tissue is stuck. Then I fix that.
Mm-hmm.
And then I fix their rib cage, because if you can't breathe, you cannot function. Because who is the biggest sister to your pelvic floor is diaphragm. So I fix their diaphragm and I teach them how to breathe 360, especially posteriorly, to include their serratus anterior and their lats. Oh, and then of course I release the connective tissue of the legs, and then I go internal. Only then, and this patient's like, whoa, that's like visit number 4. How come you've never been inside? And I go, why? Why am I going to give you a gynecological exam, which is torturous, and then you're going to get up, and then it didn't benefit you? But I explain to them. They go, okay, I get it. And what I also do, because you have to motivate these patients to come back. Nobody wants to come back and lie down and drop their pants. Nobody. So what do? I say, the next visit, this is what our goal is. And I go line by line. And every session, we have a new goal. And when they come back, I always say to them, what made you flare? Is anything bad? Do we have any gains? Do we have any losses? And I write it down. And I adjust the goals according to what I have done in the previous session. So there's always this going back and forth. So the patients are not passive. They have to come back and tell me, what did you do? Is it better or is it worse? So because I need to know there's all of these forks in my road, am I going in the right direction? Or am I doing the same thing over and over again? Right? We can't have that.
Mm-hmm. Okay.
Right?
Yeah, I'm stuck on this 360-degree breathing.
Mm.
Is that something you can give us a quick intro to?
Yeah. So 360, we breathe. So there's a woman, Mary Massery, that teaches a class that says if you can't breathe, you cannot function, right? And she nailed it on the head. So we usually, when we have anxiety or we are runners or we're stressed, we tend to breathe with the, the cusp of our lungs and the upper trap and scalenes, all the upper neck, right? So if you see somebody who's stressed, they breathe like this. I'm like, whoa, slow down. You're hyperventilating. And it always upregulates them into sympathetic response. So they're stuck in that cycle. And they come into you and they're like, my neck, it's so painful. I could never release my neck, right? And I'm like, because your breathing is doing it. Okay. And then I'll say to them, can you, and I'll put my hands on them, like, breathe into my hands. And of course, they're perfect at this. They go, I go, excellent. Can you breathe into your clavicles? They go, and remember, your clavicles have to rotate up and down when you're breathing. This is what your clavicles are doing. So I release subclavius under your clavicle to make it go up. Your clavicle is attached to your shoulder and your scapula. So if this is not moving, you're all getting your shoulders and your scapula stuck. It's going to affect your spine. So I spring this as they're breathing. So, and I teach them, this is what you have to do as you're breathing. And then I say to them, breathe into your rib cage, breathe into your sides, breathe into your diaphragm. And then I take a sheet. I'm cheap. I don't have equipment because they have to go home and do this, right?
Well, you just had a sheet right next to you.
Yes, I did. Right. And I say to them, take a sheet, wrap it around your torso, right? It's wrapped around and tighten it. So now that compresses your rib cage, doesn't it? So now when you breathe, it gives you strain, counter strain. You're going to breathe against resistance, and it strengthens your intercostal muscles. So breathe in, hold it, and then blow out. Breathe in, hold it. That stimulates the posterior structures. We never, ever breathe into our back. So the back of our lungs don't have to work. So your diaphragm gets stuck in your lumbar spine because your diaphragm is shallow up front and the back of it goes and inserts like a little tuxedo tail into your L1, L2. So that's going to get stuck. So it doesn't matter how much you're releasing your diaphragm. That's stuck because you're never breathing with the back muscles. That's your 360. And now I say to them, shallow breath, medium breath, deep breath. And they have to put their hands on it because these are our receptors to the brain, right? I'm like, always put your hands on it so your brain knows where you are located in space. That's 360.
Okay.
Yeah.
And how often do you recommend somebody practicing that?
Every day, twice a day. And I say to them, take 2 minutes in the bathroom at lunchtime and take 2 minutes before you eat dinner. That's all it takes. It doesn't have to be that big. You drive in a car, do it in a car. You could just use one hand and do it. As long as the body gets a feedback. Yeah.
Mm-hmm. Interesting. Okay. I'm gonna try that today.
Also, you could take a bowl like this. Yes, I have a bowl in the room too. And then you could lie down right where your sternum ends and lay on the floor and breathe into it. It releases your inferior sternal angle. And that's where women get stuck all the time. And instead of this, it's going to bring you in this position. And now your rib cage will expand.
Mm-hmm.
Right? Teeny tiny bowl. You don't have a bowl, fold a towel and shove it right underneath that little sternum. Yeah.
Okay. Got it. Okay, so we got sidetracked because I wanted to learn about that. What were we talking about before that?
I have no idea. Breathing.
Oh man. Okay.
Menopause.
Yeah, we were talking about.
Pain with sitting.
Oh yes, yes. Perfect little segue to that.
Yes. So a lot of menopausal women come to me and they say, I cannot go see my friends in Long Island. It's because it's a 2-3 hour drive. I could sit down, I start driving, half an hour later, I feel that buzzing in my pelvic floor. And they always point to, here's my sit bones. It starts close to my butt and it travels behind my thigh. They're like, what is it? Is it sciatica? I go, no, it's not. It's not. And I was like, so of course, I already assessed their sacrum. I know they could do pelvic tilt, right? And the connective tissue around their booty has been already cleared and they still can't sit. And I go, well, we have 3 nerves coming out. We have sciatica, posterior femoral cutaneous, and pudendal nerve. Sciatica goes down the leg. You're going to feel it immediately from your booty all the way down to your knee. Posterior femoral cutaneous is going to be right by that sit bone and beginning of your thigh, in that butt crack. That's posterior femoral cutaneous. If it's a pudendal nerve, only 4% of sitting with pain is pudendal nerve. So we don't even say that nerve. But I say to people, do you feel when you're sitting, do you feel it in your butthole, in your perineum, or in your genitals? If they say no, that's posterior femoral cutaneous. And you're like, how does this apply to menopause? We lost muscle bulk with menopause, right? We lost structural stability. So when we're sitting in the car, we are all crooked because we can't sit still and we have no fat protecting our nerves. So we're just sitting on top of them with our sit bones. Bones have not decreased and we're compressing our nerves and they're firing back at us, giving us pain. Yeah. But you and I could do this whole episode about pudendal nerve if you wish, because I know there's so many people who want to know everything there is to know about this.
Yeah, definitely. I have so many clients that complain of pain with sitting.
Mm-hmm.
And now that we're talking about it in terms of menopause, I would say most of them are postmenopausal. So that is really interesting.
They need to build their glutes, right? And which is very difficult because glutes are very reflex. Glutes and your hamstrings and your adductors, they react to reflex. So they have to be worked out every single day. If you don't work out your glutes today, whatever you did for 3 months is going to go away. Mm-hmm. That's how quickly you lose your progress. So when I see women with big, giant glutes, I applaud them. They're so disciplined. Not me, but they are, yes.
Yeah. So what kinds of exercises can people do to maintain their glutes or build their glutes?
They could, because glutes have 3 heads on either side, right? The main one that really talks to us is gluteus medius. They could do bridging. They could do clamshells. They could do squats with either toes in neutral or a little bit rotated out like ballerina and gently squat. They could do monster walks with the bands around their knees, up and down the kitchen. If they Google gluteus medius exercises, they will probably get 700 exercises, right?
Okay, perfect.
Yeah. I think for the easiest for the women, lie down and do your bridges and squeeze your booty on the way up. That will also help you with prolapse because your organs will slide right back into your abdomen.
Mm-hmm.
Yeah.
Okay. All right. Well, is there anything else you wanted to mention about menopause or anything we talked about before we wrap this up?
I think for menopause, even though I know it's a new chapter in life and it's really not that exciting, I think women feel like they have to run to the doctor and get the hormonal replacement therapy, and that's the end of it. No, ladies, it's opposite. The kids are out of the house. It's your time, right? Go to the gym, right? Do the sauna for detox. Eat really good food because remember, the kids are out. Now your budget is bigger. You could buy organic food now and get your sleep. Go to bed at 10 o'clock so you have melatonin and growth hormones kicking in and repairing you. Put castor oil all over yourself for anti-inflammatory. And really try to also not to stress out. We already passed all of those times. We're not chasing our careers. We're just now going into the time where we're enjoying ourselves and laugh more, relax more, sleep more, and take a bath, magnesium bath. My God, that's such a dream of mine to spend 20 minutes in the bathtub. But you could do so much more to start repairing your body instead of thinking that my body is failing me. No, it's opposite. Now you're just repairing what has been broken, and now you're just seeing it because the hormones are leaving you because they've been holding you together like glue.
Mhm.
Yeah.
What I'm hearing is we need to prioritize ourselves, ladies.
Absolutely. Yeah.
All right, perfect. Well, you gave a ton of awesome tips and actionable steps people can take. So I'm going to also link to your blog in the show notes because that is a gold mine of helpful information on so many different topics that can help both women and men. Are you, I don't know if this is, I feel like I know the answer to this. Are you on social media like Instagram?
I am. Yeah.
Okay. Where can people find you?
Pelvic Health NJ.
All right, awesome. We'll link that too. And then lastly, are you accepting new clients right now?
We are. Yes, there's 4 practitioners. We all work full time. We see patients Monday through Sunday, 13 hours each day.
Wow.
Yeah.
Amazing. Well,
Yeah.
thank you so much for taking the time to come on here and just be authentically who you are. I really enjoyed talking to you and definitely would want to do a part 2 to this and talk about pain with sitting even more.
Absolutely. Thank you so much for having me. This was so much fun.
Yeah.